try to set my stopwatch because I'm a serial offender for going over time, but I've actually set my alarm, I think, so we'll just see where we go. Thanks to Alzheimer's Europe for the invitation to speak here, and thanks to so many of you for staying around. I thought there'd be like 2 people and a dog in here at this time of night, but I think it's testament to the conference that you're all still here. I'm going to try and stick to time. I'm going to whip through this in my usual fashion of using PowerPoint like a drunk man uses a lamppost. So I've got far too many slides, so I will whip through it quickly. But I want to give an honest account of where we are with acute care in hospital, some of the challenges that we face, and maybe where we are now and where we want to progress to. So why, let me just see, is the clicker that way or that way? There we go. So, why acute care? Well, it's been both of our dementia strategies. It was a key action in the first one. It remains a commitment in the second one. Why is it there? 2 reasons. The first theme is absolutely in line with the conference. Myself and the Chief Nurse, Ros Moore, went out to meet members of the Scottish Dementia Working Group before I really knew the Scottish Dementia Working Group, or they knew me. And I think Barbara, who's here, was in those sessions, and Ros and I both absolutely know that they were the most difficult conversations we've had in our entire nursing career, and it spans quite a long time, I can tell you. The accounts that people gave of their experience absolutely inspired us to make sure that we were committed to change. But also at the same time, there was a whole raft of reports that showed that the care of older people, people with dementia in acute hospitals, was just not up to scratch. So it has remained as a key strategy resource. I'm going to I'm going to just really flick through this quickly, but why is acute care important? There's been some papers and discussion of it at this conference. I was a bit surprised there wasn't more, because it seems such an important area, but that's maybe just something to think about why that is. So what are the issues? Well, from people's experiences, we know that there are greater risks to people with dementia in hospitals than for other patients. They're stressful, they're noisy, they're unfamiliar. Difficulties with communication can lead to issues around nutrition, physical falls. All of these issues we know can happen. Don't always happen, but can happen. And that people can quickly lose their own independence and autonomy in hospital settings. We know that. The research has shown us that. What do we know about what it costs the system? I'm going to flick through this. These slides will be there for you if you want to look at them afterwards. But we know that currently in Scotland, at least 2/3 of beds are occupied by people over 65. We know that about 1/3 to 40% of people have dementia or some form of cognitive impairment. We know that people are twice as likely with dementia to have a hospital admission. And so we know that there are issues. What we don't know, the data is poor because of the coding system, and we need to really develop that. If anybody from any country's got a great coding system that works really well and gives you good data, I'd love to hear about it. And the other issue, which we definitely know from the data that we have, is that length of stay. People with dementia, on average, stay twice as long in hospital than those people without a diagnosis of dementia for a similar condition. And clearly, the cost to that of the individuals, as I've already said, is huge. But the cost in terms of resource is also enormous. We heard earlier on about the differential in cost, £4,600 a week for acute care, compared to what that could be for care at home, etc. So in summary, people with dementia are more likely to have a hospital admission, stay in hospital longer, and that has an associated cost. Now, I want to talk a bit about changes outside the hospital, because it's not, the acute hospital setting is absolutely essential that we focus on that, but we have to understand that this is not just about acute hospital care. And in fact, that's probably been one of the issues that we've faced for a long time, is that acute hospitals have tended to sit on their own as these huge, powerful buildings that consume a huge amount of resource and have a huge amount of power, and perhaps haven't reached out to other sectors. Our healthcare strategy around quality, safe, person-centred, effective, our 2020 vision for care in Scotland is for health and social care, has several components, but 2 of them are that people will get care closer to home. and that people will not have unnecessary hospital admissions. So those two things are critical in thinking about hospital care before it happens. Can we have care closer to home, and can we avoid this? And I'll just highlight one team. This is the asset team, a specialist team from Lanarkshire that works, that is multidisciplinary and takes referrals directly from general practitioners, aims to respond within an hour, and rather than the referral going to the hospital. And I'll just, go back. And on this graph here, you'll see that the admission rate for people over 75 without asset team is nearly 12%, but with asset, where asset operate is less than 2%. So there are services, there are ways of working that can significantly reduce whether people are admitted to hospital. And similarly, we have to remember that there's a whole raft of other policy out there that can inform the work in hospitals. It's not just about this acute hospital work. So work around learning disabilities, our scrutiny work, person-centered care, work on sensory impairment, all of this, end-of-life care, all of this will inform acute care. Alongside that, and this morning when Amy was describing the 8 pillars model, which is clearly is associated with ensuring that people have the best physical health care, and that's part of the Dementia Improvement Programme, National Dementia Improvement Programme, now called Focus on Dementia, and those aspects of it are absolutely critical to bring together and not again have this piece of work that's isolated in terms of acute care. Amanda Johnson, who's here, put your hand up, Amanda, give us a wave. Right, there she is leading out the work of improvement around supporting our 10 care actions in hospitals. So that's essential that we join all of that up. I'm going to skip through these. No, I'm not going to skip that one, because they'll never forgive me if I did. But changes at the front door, changes as people come into hospital. We've been doing a lot of work through our Older People's Improvement Programme to understand better this whole issue of cognitive impairment, which, to be honest, acute general hospitals have not, on the whole, dealt with terribly well. We've done a whole raft of work about understanding cognitive impairment, about delirium, and about really thinking about frailty and how do we recognize that and how do we work with that at the front door. And this is the kind of work that's been coming out of that excellent piece of work. We have a scrutiny program of inspections. We've inspected 32 hospitals. We continue that. It informs everything we do. So commitment 10, acute care in Scotland. These are our 10 care actions that we launched last year. And this was a result of all of the work that we've done of continually hearing that these are the 10 things that, if they were done well, would make a huge difference to the experience of people with dementia and their families in hospital. Now, you've seen them at various points during the couple of days, so I'm not going to go into them in depth. But I think since we launched them about 18 months ago, they've stayed pretty much as they are. And in fact, they seem to be those things. So if you're looking for 10 care actions, this would be a good basis, I think, on which to start from. I want to highlight just these two here. And I want to talk a bit about where we think we are with this and what we think the issues are. Why has acute care, general hospital care, perhaps had these issues and where it needs to go? Why has that happened? And I'm referencing our illustrious chair today, Henry, and I hope this is partly a result of Henry and I's discussions. So that first slide, the second care action is to develop the workforce in line with promoting excellence, which is about dementia skills. But why do we need to do that? What are the issues for acute general hospitals? Since 2009, we've been around hospitals, both Henry and myself and Ros Moore and all of the team, continually meeting, working with the Scottish Dementia Working Group, with NDCAN, to understand, to talk to staff about what are the issues. And often we heard these negative paradigms, this notion that for professionals, for healthcare staff, working with older people, working with dementia was often seen as an area that you didn't want to get stuck in, that the care of older people is not necessarily that skilled. Just asking, why are there so many older people? Why are there so many people with dementia in our acute general hospital? Could we have a dementia ward? Could we do something like that, or a dementia unit? And just people feeling that they're just not coping. And what we've been trying to do through our work is create a new paradigm. And I think undergraduate education is mentioned a few times, and it's absolutely critical that for undergraduate education, those educational staff who are in the room are critical in developing and pushing that new paradigm with our new students, no matter which professional group they come from, that this is a highly skilled area of practice, that it is the most common presentation, that it is that you do need the skills and the confidence, and that we can provide quality of care. And sometimes I think lack of confidence is often what is perceived as being uncaring, and the two are confused. It's a lack of confidence often that is seen as, that portrays that. So I don't know if you can see that too well, but what we're trying to think about, and Henry talks a lot about psychological contracts, particularly when people went to work in acute general hospitals, they kind of had a psychological contract about what they thought they were going to do in that area, and that's changed. So that they often, it leads to the fact of stress, of poor care, of about trying to think, how can I move this problem on, rather than thinking, how can I embrace this, how can I engage with this, how can I lead this work? And I'll show you a few things that we've been trying to do that. We've jointly funded nurse specialists. You've heard a lot about them. There's a few in the room still. They're probably obligated to be here. So, well done. And I've ticked the ones that are gone, so I'll remember them. And they, you know, and that's something that, you know, I'm very happy to talk to any countries that are interested in developing that. Henry and I have worked with this for years. It's making a huge difference, but it's difficult, and it is a new concept of having, in a smallish country, 12, 14 specialist nurses at that level working on a single issue. We've trained 500, and it will be soon over 600 dementia champions. And for being a small group, and people saying, oh, well, it's just a small group, it isn't anymore. It's a critical mass. They're making a difference. If you think there are 40 acute general hospitals in Scotland to vary in size, all of them have a good number of these dementia champions. And allied with the specialists, they make a difference. All over Scotland, we now have this network of change agents, of bringing that positive paradigm to the work. And I just want to mention our allied health professionals, who I was talking to them yesterday, and I was saying, I need to meet up with you, because they're leading a lot of work. They're really driving forward, and I think showing a lot of the professional groups how to do this. Now, this second one, I just wanted to highlight something positive about person-centered care. The nurse specialists have developed Getting to Know Me, which is all about a history of that person, understanding the person, and then being able to do person-centered care planning. But I want to just focus, if I can, Henry, for a couple of minutes on developing a safe and therapeutic environment. What we've focused on to date with this is a safe environment. So we've seen a lot of changes in our hospitals, and it's fantastic to see it. A lot driven by the champions, specialists, others, to the fabric. We've seen things like clock signage, colors, and so on, and that's terrific. We're beginning to see some more deep-rooted changes. This is about, in the NHS Lanarkshire, a really innovative system looking at noise on the acute ward. So trying to reduce noise levels, and it electronically shows what the noise level is on the ward, particularly at nights. We've talked about that. We're seeing the development of garden areas. And this is where we start to think, well, hang on a minute, where are we heading here? This is acute general hospital care. Is this where we're heading? Is this what we want? So we're seeing things like social areas starting to come back into acute general hospitals. They disappeared. We're starting to see dining rooms coming back. We're seeing meaningful activities being carried out in acute general hospital wards. And it's probably, these are great, I think, but we need to think about what is the purpose of acute general hospital care? Is this the direction of travel, and where do we take this? Now, I'm going to dreadfully pronounce this, but Nella Sprout yesterday, that's dreadful, isn't it? But that's my best attempt. In a session yesterday, really kind of got me thinking. What she said we're talking about care homes. The way we see dementia and dementia care models will reflect the way that the environment is designed and organised. And I don't think we've thought that through yet. We've thought about some changes, but we haven't really thought about what's the model here. And I, unfortunately, was lying late in my bed last night, not being able to sleep. And I thought about the Berger and Luckman, the social construction of reality, and about how people have taken on roles that then become the accepted norm, and through that a system becomes the accepted norm, and the system can only see that way of operating with people within that. So what I think we're saying is that we've got an old paradigm for acute care, which was treatment and cure focus, which was about a single clinical speciality, orthopedics and so on and so forth. We had mental health and geriatric specialists who sort of came in and did things from time to time. We had a clinical milieu. It was about clinical work. It was about traditional staffing, professional care, and it focused on secondary care. What we need to do is now shift that paradigm to think, yes, it's still about treatment, clearly, but it's also about reablement, rehab, and recovery. But how do we do that in an acute general hospital setting? It's about multiple conditions. It's about the therapeutic milieu. So social areas and so on. Is that the direction of travel? It's about shared care with families and carers. It's no longer about professionals just doing to people. People don't want that. And it's about understanding how they link with primary and social care. It's about staffing. We have to understand if the population has changed in general hospitals, then the staffing should change too. The mix, the speciality, what people need to know. And in Scotland, we have a national programme of workforce tools for giving us information about what staffing should be. And we're really, really working hard to make sure that these reflect the needs of people with dementia and being able to enact the dementia standards. So that's my final point, that it's about a multifaceted, multi-agency, and I sort of agree with that, and I do. But I also think that we cannot take our eye off the ball, that it is about acute hospital care when it happens, when it's necessary, that it is about person-to-person care, and it is about ensuring that that's compassionate and it's caring. So thank you very much.
Thank you very much, Hugh. That was an excellent presentation. I'm sure inspired many people. I'll take a quick question if anyone's got. Oh, you'll get some people just at the front here. Yep.
My name's Lynn. I'm here with my colleague Janet. We're from England, and in relation to improving the care for older people, and particularly older people with dementia on acute hospital wards, we've been working with Dr. Sophie Edwards, who's the consultant geriatrician at the North Middlesex Hospital, and in particular using massage. So we are helping to train any of the staff on the ward to be able to carry out massage with patients as a shared experience, and also something to improve communication, interaction, and the reduction of behaviour and stress. And this has been working very well. We haven't heard anything about massage, so I was just wondering if it's something that is part of your therapeutic interventions that that have been mentioned as part of the 8 pillars, and also you were just on your 10 there, you had about a safe and therapeutic environment.
Sure.
Yeah, I'm sorry. Yeah, I mean, I absolutely have completely agree that there are a whole range of things that can be done that would help people in acute care. But my argument is still just to think this through and think about what is it we're trying to do in acute care. Because to be honest, the baseline is that people shouldn't go in unless absolutely necessary. And as soon as people are able to leave, they should leave. Now that should be the baseline. I don't think anybody would disagree with that. So what is it that we're doing in that time that makes sure that that's what happens? And there's the focus absolutely on that, or can and should these other things be happening in other settings? We're seeing the rise of intermediate care, of community hospitals again having a crucial role, and care homes who are providing more and more acute care. So is that the setting where that approach and those therapies should take place. So that's all I'm saying is we just need to, rather than pick one thing out, we need to think about the round. What's the round here? What's that package of acute care? It undoubtedly has to change, and there are techniques for absolutely sure, but I just want to be sure about what are those techniques that we should be doing, and what is the focus and purpose of acute care.
Yeah, I think it's very much about supporting the person with their experience in hospital. And I think it's been mentioned at some of the other talks that I've been to, and from my own experience, that staff find it very difficult perhaps to manage patients in certain conditions, and finding tools like that can help. It's a bit like probably, I don't know, in the music side, playing music may then allow staff to carry out certain things that they need to. And we've had some very positive feedback, because if nothing else, it's about touch, it's about compassion, and I think that's what you said is missing.
It's also about stress and distress training, and I think that's traditionally something that general hospital staff wouldn't have and now are getting, and that is making a huge difference to how they think, conceptualize, as I said, that paradigm of what's happening here, and actually having techniques to help. So great.
Great. Thank you for that contribution, Hugh. Thanks once again for that presentation and for continuing to drive forward this agenda. Can I just ask you to give him a warm thank you again?